In the past, we often did large-scale bone grafting using non-resorbable membranes such as titanium membrane to increase bone height or increase bone width. Even with successful grafting with that kind of non-absorbable membrane, after 10 or 15 years follow-up shows if periodontal disease like periodontitis initiate, extensive bone grafting initiate. In many cases, it resolved back to original bone natural height or width. These issues are particularly frequent in anterior area. Once resorption starts, it happens very quickly. Because of this, the trend in dental surgery paradigm shifted to minimalism concept. Simple GBR to avoid bone resorption after extensive bone grafting. Why has simple GBR become possible? First, it's driven by patient demand. Patients want to get the less traumatic minimalism treatment from the operator. Second, thanks to implant advancement. Implant with superior strength, such as bright tissue level, as mentioned before with Dr. Rim and Dr. Zhang. The tissue level fixture allows us to serve narrow reach cases and short reach cases without invasive, extensive bone grafting. Because of this, we can achieve minimalism treatment in Korea. The trend in Korea has shifted toward minimalism in treatment. The goal is to place implants using the least amount of bone graft materials. We can now use bright tissue implants in diameter of 3, 2.5, and 2 millimeter in Korea. But as you know, in China, you can use more than 3 millimeter, but I think after a few years, you can use 2 or 2.5 millimeter diameter tissue fixture too. Even in cases with vertical bone deficiency, tissue level fixture provides a straightforward solution to clinicians. This is the philosophy of simple GBR. Superior strength enables simple implant treatment even in cases that previously required large-scale GBR. Thanks to material intelligence, surgical efficiency, and predictable healing of bone graft, we can significantly achieve minimalism simple GBR treatment. Let me show you a clinical case of simple GBR with bright tissue implant. This is clinical photo. As you know, as you can see, the anterior ridge is very thin. This area. This is 1 month after extraction to canine area. I decided to use bright tissue with minimal bone grafting. I planned 2 implants, 2 area. I placed 2.5 by 11 bright tissue implant at both sides. Despite using 2.5 millimeter diameter fixtures, the ridge was so thin, upper part of the fixture was exposed at labial side, both sides. So I decided to do the bone grafting at both sides with minimal, simple GBR. If I had used more than 3 millimeter diameter, as you know, the standard size, regular size of the implant fixture is mostly a 3.5 millimeter diameter fixture. If I used If I had used more than 3.5 mm fixture, the exposure would have been much more large extensive. Since the defect condition was not unfavorable, I determined to do the simple GBR. I connected to scan converter cap, and I just placed the particle bone, osteogenic particle bone, at the labial side. The gingival type was thick phenotype, so I did not do additional treatment at this case. This is post-operative radiograph. You can see the two fixtures are well placed in both areas. This is the post-operative CT after 2 months. You can see that the fixtures are well positioned in the cancellous bone area on both sides. As the previous lecture showed, the bright tissue fixture should be placed in the cancellous bone area, within the cortical bone area. If we place the bright tissue fixture within the cancellous bone area, we can shorten the osteointegration period, less than 2 months. In this case, the labial exposure has been successfully covered by osteogenic, and the grafted bone was well maintained at the site. Proper placement like this lead to a good prognosis and allow for faster prosthetic connection. This is the final prosthesis after 2 years. The tissue wave implant has made it simple to finish the treatment despite in very thin niche situation. Bright tissue wave is 2-body type. It's not a 1-body type. So we can use the SCRP type prosthesis treatment. This makes long-term maintenance and measurement much easier for the patient. If we want, we can detach and connect the prosthesis anytime. In most simple GBR cases, complications are rare if we follow a few principles: minimal incision, precise packing, reusable membrane. Total 3 factors, we can achieve primary closure and stable regeneration. These factors are the essential factors for stable bone regeneration. First, I would like to talk about membrane selection. I select membrane requirement on defect containment. As Dr. John mentioned, we can choose the membrane requirement depending on the contained morphology, contained defect or not. First, if the defect is well-contained defect. For well-contained defect, such as intact forward extraction socket, or the gap is less than 3 mm, especially patient with a thick phenotype, the use of membrane is optional or simplified. If we can do the primary suture without additional treatment, like a leveraging incision or other invasive treatment, the use of membrane is optional. In these cases, I focus on achieving primary closure. However, the next non-contained defect, such as 1 or 2 word defect, in this case, it requires vertical augmentation or other extensive bone grafting procedure. Or a thin phenotype, in these situations, we should use membrane, such as collagen membrane. I utilize a combination of particle bone and collagen membrane with, if necessary, collagen graft in this situation. Today, I would like take a closer look at precise packing. I believe it is one of the most essential, important step in simple GBR. Especially precise and careful packing, careful application of the grafted particle bond to the defect site, it can lead to better and faster clinical outcomes. For successful result, we should choose the right particle bond according to these factors. First, natural pore architecture for optimal scaffold function. And second, hydrophilicity for easy handling or layering. And third, uncompromising volume stability. And finally, the particle type design can reduce surgical time. They are very important to make the great clinical outcomes. The interconnected pore size is very important. The pore structure is very important. Macropore larger than 100 micrometer induce angiogenesis. Macropore less than 10 micrometer, it facilitates osteocyte adhesion to promote bone regeneration. It is critical to use a bone material with a pore structure similar to human bone. The pore structure similar to human bone is very important. We checked the pore structure of the particle bone and the genobone before using in clinical situation. I prefer to use bovine bone for simple GBR unless there is a specific contraindication. Its volume stability has been proven through many studies. In addition, there is a substantial amount of histological and clinical data supporting the uncompromising volume stability. You can only truly appreciate the value of hydrophilicity once you use the product. I always check the hydrophilicity of the bone graft material prior to use in clinical practice. Even among many different kinds of bovine bone graft, the level of hydrophilicity is not the same. High hydrophilicity is necessary for rapid blood clotting and to induce stable bone regeneration. Based on these factors, now I'm using Osteon Geno bovine particle bone. I have been using Osteon Geno for all my simple GBR cases for the past 5 years. It's chemically and structurally comparable to human bone structure and human bone capability. I use small particle for narrow and small defect, and I use large particle for large defect or vertical, horizontal, extensive bone augmentation. Osteon Geno overcomes common surgical challenges. It is highly hydrophilicity. It has high hydrophilicity, and it can ensure the immediate cohesion upon contact with blood. And fast, stable, and precise particle placement with different two size particle type product. And we can achieve simple bone grafting effectively as a standalone genograft Osteon Geno. I will show you a case. Let's look at a case involving a cystic lesion. As you know, the prognosis of bone grafting after pathology problem, like a cyst inoculation, especially in the third molar area. The progress is not good. It is much harder to predict than implant cases. This patient presented with suspicious dentary cyst at left lower third molar area. I decided to remove the third molar with cyst inoculation. After cyst inoculation, I did bone grafting with Austrian Geno, and the grafted bone particle was covered with collagen membrane. The clinical healing was excellent. You can see the site at the time of suture after 2 weeks, and 3 months later, 6 months later. Despite the high risk of wound dehiscence at the third molar area, but there was no any specific issues like wound dehiscence and infection at this site. This is 3 years later. You can see that the bone has formed very well with sufficient bone density. I conducted a multi-center clinical study with 30 patients using this combination of Austrian Geno particle and collagen membrane. This study demonstrated stable bone formation even in extensive bone graft. Seeing these results in pathology cases gave me great confidence for using in implant cases. So now I'm using only Austrian Geno particle bone in simple GBR cases and most of the bone grafting cases. There is one thing I'm very careful about when using particle type bone. I only apply light pressure, not moderate, not heavy pressure, to crush the particle when the bone defect is less than 2 or 3 millimeter. For standard size defect, I never modify the particle shape to ensure the macropore structure of the Austrian Geno particle bone. The application force for the bone particle bone has been evaluated in several studies. Applying force more than 100 Newton is highly likely to completely destroy the pore structure. So we should keep the pressure less than 100, but ideally keeping the pressure under 30 Newton will make better clinical result. Based on these criteria, let's look at a clinical case of implant treatment combined with simple GBR. This patient required 2 implants at left upper lateral incisor, canine, and first molar. Fortunately, the bone width was sufficient to place the regular size implant. So I decided to place 3.5 millimeter bone level bright implant fixture. The bright implant system has Lindemann drill kit, so it is very easy to set the initial drilling point as we want. Sometimes I use this Lindemann drill to cut the tooth or to grind the bone, ostectomy or odontomy, because the blade is very sharp to modify the bone shape. So I usually use the Lindemann drill to modify the shape of the bone or cut the teeth. After placement of the 2 pictures, now I'm doing the bone grafting at the buccal side of the 2 pictures. In the lateral incisor area, the number 22 area, the defect size was narrow, so I used the small particle bone of Austrian Geno. And first molar area, number 24 area, I used the large particle bone of the Austrian Geno. Here are the two bright bone level fixtures placed in the lateral incisor and first premolar position. I used the different size of the osteon Xeno particle bone. I always select the osteon Xeno according to the size or morphology of the defect. And after that, now I'm using oral pack after the surgery. It is typically observed within 3 to 4 days. In the meantime, it helps stabilize the bone particle in the defect and provides essential wound protection. This product is very convenient because it can be used directly from the tube without mixing. The next case is a lower anterior case. I plan to place a single implant in incisor area, lower incisor area. As you know, single missing cases in lower anterior area, we usually recommend bridge implant treatment. This is because the lack of major distal space and labiolingual space make it difficult to find the proper size of the implant fixture. But this patient wanted to get a single implant because if we provide a bridge treatment in this case, the bridge, the adjacent tooth processes should be removed. But the patient did not want to get that kind of treatment. So we decided to do the single implantation with 2 millimeter bright tissue level implant. I solved these cases easily with the tissue level implant nowadays. In this case, the ridge was extremely thin, so even though I used a 2 millimeter implant fixture, a large portion of the fixture was exposed. I performed labial bone grafting using osteon Xeno. I used large particle osteon Xeno. The defect condition was not contained and unfavorable, so I covered the site with a collagen membrane of dentium. And after that, I tried to use collagen graft, but there was not enough space to apply collagen grafts, so I just do the primary closure as possible. This is a clinical photo after primary closure. Scan comfort cam was connected to the fixture. I get the sufficient initial stability. A fixture was well placed between the two teeth. I connected the final prosthesis after 3 months. We can make a SCRP type prosthesis with bright tissue level implant even in the narrow anterior area. It allows us for easy long-term maintenance by simplifying the removal and reattachment of final prosthesis. In this case, I will show you how to easily finish the treatment in the upper anterior area with simple GBR. This patient needed 2 implants at upper anterior area. After flap elevation, you can check the width of the alveolar ridge. It was less than 3 millimeter. It's about 3 millimeter. The opposite side is also very narrow, so I plan to use 2.5 millimeter and 3 millimeter diameter tissue level fixture. If you want to use a 2.5 millimeter bright tissue level fixture, we only need to drill once with a 2.5 millimeter guide drill. So we have only single chance to make the initial drilling point. If we want to use the 3 millimeter fixture, we need to drill only twice. So we should be careful of implant drilling during using the implant bright tissue level fixtures. After drilling, I place 2.5 millimeter and 3 millimeter bright tissue level fixtures. Minor exposure was exposed upper surface of the fixture, so I decided to simple GBR. I performed the simple GBR using Collagen Membrane, small particles. After that, the gingival type was 6 phenotype, and I can achieve primary closure. So I just did the simple GBR at this condition, and this is the CT after 2 months. The exposed upper part is well covered by the general particles. So I connected the final prosthesis after 3 months. The final prosthesis can be connected within 2 or 3 months if the fixture can be placed in the cancellous bone within the cortical bone area. Due to the severe ridge atrophy, I used pink porcelain. If I used collagen graft or after this procedure, if we can use the filler like Mona Lisa filler, we can enhance the contour, anterior contour, aesthetic clinical outcome using that kind of product. But it is important to explain about the aesthetic insufficiency to the patient before treatment. This is the 1-year follow-up. It shows stable outcomes. 2 years later, the implants are maintained without any issues. Let's summarize today's lecture. Simple GBR has become possible thanks to bright tissue-based implant system and the patient demand for less invasive surgery. I recommend Collagen Membrane for its long-term stability and pore structure similar to human bone. Remember to use large or small particle appropriately for the defect size, depends on the situation. And apply light pressure to maintain the pore structure of the Collagen particle. Minimal treatment can be the best treatment. So I always recommend to do the less is more efficiency treatment concept. Thank you for listening. I hope you have a wonderful and memorable experience in JEJU Island. Thank you.